everyone, today's video is about occlusion. Now this is due to popular demand because I have received so many messages asking me to send notes about it to help explain it, and I thought if there's any way I could make a video that makes one person understand it a bit better, then that's worth it. So hopefully you find this useful. If you're not working in dentistry, you're not a dental student, then it will sound like a load of rubbish, so skip past this one, but hopefully it'll be beneficial to some people. I will be using notes throughout because it's a topic which I think that most people find confusing, so I don't know all of this off the top of my head. I will still be referring to my own notes throughout just to make sure I can explain it as clearly as possible. So I'll pop up some little pictures and diagrams throughout and subheadings to try and break it down, make it a bit clearer, but if you do have any further questions after, then please drop me a message and get in touch. So what is occlusion? Basically, occlusion is a relationship between the teeth and the top and the bottom jaw when chewing or at rest. There are two things that determine occlusion, so the position of the teeth and the position of the jaw, so the maxilla, which is the top jaw, and the mandible, which is the lower jaw. So we'll just start with a couple of definitions which I'm going to put on the screen. Now most of these are from the workbook which I got from my occlusion course, the one I've already discussed, the Advanced Centre of Excellence, so these are going to come up on the screen as I'm talking you through them. So firstly is the ICP, or the intercuspal position, and this is the relationship of the mandible to the maxilla when the teeth are maximally interdigitated. So this is basically as the teeth meeting together, and it's the contact between the greatest number of opposing teeth, so it's tooth determined. So the centric relation position, or CR, is the relationship of the mandible to the maxilla when the condyles are in their most superior positions in the glenoid fossa, with their anterior surfaces acting against the posterior facing surfaces of the eminentia. And I always struggle with that word, so hopefully that makes sense. Now CR can be maintained over a range of vertical dimensions, so it's not an explicit clinical description of a jaw relationship unless the vertical dimension is specified. So alternative terms for the centric relation are the centric jaw relation, the terminal hinge axis relation or the terminal hinge relation, and the retruded axis position, so the RAP. So you might hear this called various different things. And then there's the retruded condylar axis, so the RCA, which is the imaginary axis which runs through both the condylar regions when the condyles are in their CR in relation to the maxilla, and it's a relaxed and unstrained relationship, so it can be a functional position if deflective contacts and cuspal interferences are removed. And then the centric relation contact position, so the CRCP, is the relationship of the mandible to the maxilla when the condyles are in their most superior positions in the glenoid fossa, with their anterior surfaces acting against the posterior facing surfaces of the eminentia, and tooth contact is occurring. So this is the additional bit for a centric relation contact position compared to just centric relation. And in this CRCP, there's zero separation, and in 90% of subjects, there's only going to be one or two teeth meeting. So the RCP is the retruded contact position, and this is the relationship of the mandible to the maxilla when the condyles are in their most posterior position in the glenoid fossa and tooth contact has occurred. So in this position, the condyles are usually positioned downwards and backwards, but there are various things that affect centric relation and RCP. And then finally, the retruded arc of closure, so the RAC. This is the arc of opening and closing made by the mandible when it's rotating on the retruded condylar axis. So there's something known as slide or slip, which is when the patient is in the CRCP or the retruded contact position, and then they move into ICP with their teeth still contacting. So they slide from that retruded position into ICP. And around 10% of patients, there's no difference and they don't have a change or a slide. Now, regarding the relationship of the teeth, there are the static positions. So the way the teeth are like that, locked together, which is the ICP, so the intercuspal position. So when the cusps of the teeth are locked together, the intercuspal position, that's a static position. There's the dynamic position of the teeth, so their relationship in movement, and there's also interferences. So there's three key things regarding the teeth and the position of the teeth. the static relationship, the dynamic relationship, and interferences, so where teeth catch prematurely during function. Now, occlusion is really important because it helps improve the predictability of restorations that you do. It can help prevent teeth from fracturing if the occlusion is balanced, so it generally protects the teeth, and it can also reduce the tooth wear on the teeth, so the wearing down of them, such as attrition, where the teeth may be grinding together, and also it can affect the jaw pains and problems with the jaw joint itself. So I did a 3-day course on occlusion down in London at the Advanced Centre of Excellence, so I will tag this in the description box for this video, but it was an amazing course. It's basically taught me everything that I know about occlusion. It's hands-on, it was really good, money well spent. It's made my restorations much more predictable, and I'm a lot more confident now managing more complex cases. So the position of the teeth will influence the envelope which the mandible has to move. So if these are the top teeth, these are the bottom teeth, their position and their relationship is going to affect chewing, how much space there is for the mandible to move around. If it's really tight, you're going to have a reduced envelope of function, so there's going to be less space for those teeth to move. They're more likely to wear against each other. So the nearer the tooth is to the jaw joint, the more impact and influence the jaw will have on the movement of the teeth. So anterior guidance is a term which you might hear quite a lot of, and that is the relationship between the top and bottom anterior teeth, and it has two components: horizontal overlaps of the anterior teeth, which is the overjet, and vertical overlaps of the teeth, which is the overbite. So the overjet is a horizontal overlap, so again, if you've got top and bottom teeth, the top teeth are further forward, so the more that they move further forward, so the bigger increase in horizontal space is an increased overjet. And then the vertical relationship, so as the top teeth are lower, more overlapping than bottom teeth, that becomes an increased overbite. So this would be a big overjet and a small overbite, big overjet, big overbite, and small overjet, small overbite, and small overjet, big overbite. So occlusion basically means closure. So officially it would just refer to the static relationship between the teeth. But in dentistry we do use the term occlusion, like I said before, to also include the dynamic movement and the relationship of the teeth in function as well as static. So there's 4 types of occlusion which we need to consider in terms of relationships. There's incisal, canine, molar, but then there's also a skeletal classification as well. So we'll start with the skeletal classification. So there should be a diagram appearing over the screen now, which shows you class 1, 2 and 3 in terms of skeletal classification. So class 1 is idealistic, so what we would aim to achieve. Sometimes that isn't possible, or the patient may need surgery to achieve that, but in general these are the 3 skeletal classifications which we would look at overall. So occasionally a patient may have, for example, a class 3 skeletal pattern, but they might have a different incisal relationship to their skeletal pattern or their skeletal relationship. Now occasionally orthodontists will work within the skeletal pattern and sort of accept that and just try and camouflage this by moving the teeth. So that's orthodontic camouflage. So while we might not actually be able to make the skeletal and the incisal and the molar relationship all class 1, we might be able to improve the bite, improve the appearance of the teeth while still accepting the skeletal pattern or classification not being class 1. Now again, you should be able to see a diagram over the top of me narrating, and this is explaining the difference in incisor relationships. So a class 1 incisor relationship is where the incisal edge, so the tip of the incisors on the mandibular incisor, so the tip of the bottom teeth, bites on the cingulum of the maxillary incisors. So the tip of the mandibular incisors bites on the cingulum of the top incisors. So like I said, normally this is 2 to 3 millimeters. For class 2, there are 2 different divisions. So there's division 1 and division 2. So a class 2 division 1 incisor relationship is when the maxillary anterior teeth are proclined and there's an increased overjet. So there's an overjet with proclination. Now, a class 2 division 2 incisor relationship is where the maxillary anterior teeth are retroclined and a deep overbite exists. So you're going to have an increased overbite because the incisors on the bottom, the incisal edges of the mandibular teeth aren't biting on the cingulum of the maxillary teeth. You've got this increased overbite. And then a class 3 incisor relationship is when the incisal edge of the mandibular incisors, so the tip of the bottom incisors, are biting anterior to the cingulum of the maxillary incisors. So it doesn't necessarily have to be edge to edge. The lower teeth don't have to be in front, like complete reverse overbite, but it's the incisal tips are more anterior than the cingulum. Now moving on to molar relationships. So again, you're about to see a diagram over the top of me narrating, which hopefully you're finding more helpful than just my hands waving around. So when we're looking at molar classifications, we're looking at where the mesiobuccal cusp of the first permanent molar, so MB of the upper 6, occludes with the buccal groove of the lower first permanent molar. So where the MB cusp of the first upper molar occludes with the buccal groove of the first lower molar. So the MB of the upper 6, where that is with the buccal groove of the lower 6. So I hope that that makes sense explaining it like that. So in a class 1 molar relationship, the mesiobuccal cusp of the maxillary first permanent molar occludes with the buccal groove of the mandibular first molar. So they fit together, you get the MB cusp sitting in that buccal groove. So it kind of looks, you would think, almost like a class 3 because the lower tooth is slightly further forward than the upper tooth, but it's where the MB cusp is sitting relative to that groove and it sits right in it. So always just think, where is the MB cusp of the upper 6 sitting? And that's what you're looking for. If it's in the groove, it's class 1. Now, for a class 2 molar relationship, if the MB cusp of the upper 6 or the upper first permanent molar is anterior to that groove at all, then that's considered to be class 2. And then if the MB cusp of the maxillary first permanent molar is distal to the buccal groove, then that's class 3. Now, if you go from the groove up to the cusp, then that is the difference between a class 1, a class 2 and a class 3. So it's that relationship between the groove and that cusp. So when we're looking at canine relationships, we're looking at the cusp tip of the upper canine in relation to the lower embrasure between the canine and the first premolar. And you'll see a diagram again over the top of me talking, so I'm hoping that makes it easy for you to understand. In a class 1 canine relationship, the cusp tip of the maxillary canine is lined up with the mandibular canine premolar embrasure. So basically the tip of the top canine is bang in the middle of the canine and the premolar in that gap. For a class 2 canine relationship, the cusp tip of the maxillary canine is mesial to the mandibular canine premolar embrasure. So the tip of that canine, even if you have canine to canine in a static bite, so if the teeth are just in ICP, which is biting together, if that top canine is meeting the lower canine, that would be a class 2. And if that canine on the top is further back, so this is now for a class 3 canine relationship, the tip of the cusp of that upper canine or the maxillary canine is going to be distal to the embrasure, so behind that embrasure between the lower canine and first premolar. So I hope that makes sense in terms of the different relationships in a static occlusion. So this is just in ICP, so maximum intercuspation or intercuspal position. So when the patient just bites down like that. So there's no movement, there's no tongue rolling or trying to rearrange them. It's just how they meet in a stable bite. So that is what the different classifications are from ICP. So moving on to the dynamic occlusion, so the movement of the teeth when in function, there are 3 main things that we need to consider. First of all is protrusive movement, so that's when the mandible moves forward, lateral movement, so left to right, sort of grinding, sliding like this, and then also disclusion, so we'll come on to that in a minute. So protrusion is when the mandible slides forward to come to an edge-to-edge relationship. So ideally, they should be guided by the back of the anterior teeth. The lower teeth should slide along them using anterior guidance, and when you get to the point of protrusion, all of the posterior teeth should be discluded. So as you slide the jaw forward, the back teeth should come apart to protect them. So this is anterior guidance protecting the posterior teeth. When it comes to lateral movements, there are 3 types of guidance which we can consider. So first of all, there's canine guidance. Secondly is group function, or third is a combination of both. Now, something that you'll need to understand to make the rest of this clearer is what the working side is and the non-working side. So the working side is the side which the jaw is moving towards, so the mandible is moving towards. So if I move my jaw to the left like this, the working side is my left. So I'm not sure which way around you'll be seeing this looking at me, but I'm moving my jaw to the left. So the left is the working side. In canine guidance, only the canine on the working side is meeting when you're in a lateral movement. So if I slide my jaw to the left, only my canines meet on that side and all of my other teeth are open, so they're propped open by my canines. So on my left hand side I have a canine guidance because it's just the canines on the working side, which is the side my jaw is moving towards, are in occlusion. The rest are all discluded. So canine guidance is also known as a canine protected occlusion. It's also known as canine lift and canine rise. So they're different ways which it may be referred to, but that is referring to canine guidance. So group function is when two or more pairs of teeth come together in a lateral excursion and the rest of the teeth are propped open or discluded. So when I personally slide to the right like this, my premolars meet on that side. So I have two pairs of teeth meeting, so that's group function. Now, the third type of guidance is a combination of both. So it's possible that you will have canine function or canine guidance as you start to move, and then you'll change to group function. So that will be a combination, or you may be different on the left and right like I am. I personally don't have a very stable bite. It seems to change quite a lot, and I've also got quite a bit of wear on my canines. So where I used to have canine guidance, they've worn down and I'm starting to change into group function because my canines are no longer propping my teeth open in lateral excursions. And this is due to grinding my teeth, so I now wear a night guard. So you may have heard the theory that canine guidance is better than group function, but there's actually quite little evidence to suggest that one is better than the other. It's a bit easier to achieve canine guidance when you're sort of just wanting two teeth to prop the teeth open. Group function is quite a complex thing to achieve, but you do need to consider when planning changing the bites for a patient or building up their teeth, if something happens to them like what's happened to me, where the canines have started to wear down, which teeth are then going to take over the function and can they withstand these forces? And then finally we'll just touch on disclusion. So disclusion is the disclusion of the posterior teeth due to anterior guidance. This can be immediate if there's contact between the anterior teeth in ICP. So if in the regular bite there's anterior contact, then you'll get immediate disclusion of the posterior teeth, or it can be delayed, such as in a class 2 division 1 incisor relationship. So there can be three circumstances where you don't have anterior guidance. So first of all, if there's an open bite. So if when the patient's biting down, they have an anterior open bite, you're not going to get that anterior guidance, or at least you're going to get it extremely late and during protrusion, not during normal function. Secondly, if you've got a really big horizontal overlap, so that's what we were talking about near the start of the video, so a large overjet. If you've got a big overjet, during function, you're not going to get that anterior guidance. And finally, if the patient has an edge-to-edge occlusion, so edge-to-edge occlusion is basically the end point of anterior guidance. So they're already there just in their ICP. So that would be a class 3 incisal relationship. It doesn't necessarily mean they have a class 3 skeletal relationship, but the teeth meeting edge to edge means they're already at the end point of anterior guidance. So if they protrude, their teeth aren't going to be lifting off and protected anteriorly because they're going to go even further beyond the point of anterior guidance. Now, anterior guidance is really important. You might think, why on earth do we keep going over what anterior guidance is and the different circumstances around it? But it's important for 5 key reasons. So firstly, for protection, anterior guidance separates the posterior teeth during certain movements like protrusion, which protects them from damage and tooth wear, and it helps reduce the chance of these teeth fracturing. It can therefore protect restorations, it can protect vulnerable cusps, and it can also just prevent natural teeth from breaking and fracturing as well. Secondly, it's important for phonetics, so the way that we speak and pronounce things, we rely on the position of our teeth relative to each other, relative to our lips, and how our tongue interacts with those positionings. Thirdly, for aesthetics, in general, people consider a class 1 to be the most aesthetic sort of incisal relationship, so something which we need to consider. Maybe if you're straightening somebody's teeth, if you're doing composite build-ups, that kind of thing, you want to give the appearance of class 1 if possible, but you also need to consider things like lip support based on where we place teeth. Because if somebody is, say, class 2 and they've got lots of lip support, we need to be mindful that if we suddenly change that incisal relationship and make them class 1, they might feel like they look completely different, and that might not be for the best for that patient. So it's important to understand the impact the position of the teeth, especially the anterior teeth, will have on aesthetics, and ensure you think about the long-term consequences of changing this on the whole appearance of the face. Fourth, the anterior teeth and anterior guidance impact the envelope of function, so the space which the lower teeth in the mandible have to move during function. If we reduce that envelope of function, we can get more tooth wear, teeth fracturing, edge bonding, for example, with composites can start breaking off. So we have to be really careful that we don't reduce the envelope of function and restrict the teeth, because you're going to get restorations breaking off left, right and centre and much more advanced tooth wear. And the final reason anterior guidance is really important is that it protects the posterior teeth during eccentric mandible movement. So if you do a strange movement, it stops you just shattering your back teeth, because it immediately opens the teeth up and relieves the posterior teeth from being sort of bitten together. So during protrusive movements, the incisal edges of the lower teeth move downward and forward on the palatal surfaces of the upper teeth, and this mirrors the movement of the condyle in the jaw joint. During protrusion, the condyle moves downwards and forwards, so it's the same as what the lower incisor edges do on the back, so the palatal surfaces of the maxillary incisors. So next we're going to come on to interferences. So an interference is when the teeth and the jaw joint and the movements of the jaw are not in harmony. So you can often get what's called a deflective contact, so where the teeth will catch and jar the jaw or move the jaw suddenly, so it's not a smooth motion as it should be when everything's in harmony. So there are four main types of occlusal interference, and you'll be able to see these in a list over the screen. Firstly, there's a centric interference, then a working side interference, a non-working side interference, and a protrusive interference. So first of all, we'll talk about a centric occlusal interference. This is a premature contact that occurs when the mandible closes with the condyle in its optimum position within the glenoid fossa. This causes the mandible to deflect from its optimum position, with the condyles then not being in their most superior position in the glenoid fossa. So you want to be looking out for cross bites, scissor bites and edge-to-edge bites on molar teeth, where this is more likely going to be happening. And then next, for a working side occlusal interference, if the first contact is just on a single tooth near the back on the working side, this is known as a working side interference. So like we discussed previously, if you're moving to the left and it's a single tooth on the left that catches and causes things to jar or to slide, then this is a working side interference, so a premature contact on that side. So another way of describing this is basically any contact on the working side that isn't producing canine guidance or group function. So usually you'll go from that premature contact or the interference into group function or canine guidance. So you might go past to catch a tooth and then slide into one of the others. A non-working side interference is if I was going to move my jaw to the left, so a lateral movement to the left like this, but in the process of doing that, say an over-erupted tooth or a high cusp on or a high point on my restoration caught on this side, so as my jaw moves to that side, but a tooth catches here first, so you kind of get that stuttering or like juddering on the tooth, then that will be a non-working side interference. And then finally, a protrusive interference. So this is when you get a deflective contact on a single posterior tooth whilst trying to move into a protrusive position. So while you're trying to slide forward like this, I don't know why I try and talk at the same time as doing the jaw movement, but as you try and slide your jaw forwards, a single posterior tooth catches, preventing that anterior guidance during protrusion. So now we're going to move on to jaw movements. So the movement of the mandible happens in two different ways. Firstly, there's a hinge. So there's up to a certain amount of opening. This just works on a hinge basis. As soon as you want to open wider than that, after the hinge movement, you then get a translation in the jaw joint. So the hinge movement is up to 25 millimeters, and then beyond that point, that's when the translation starts to happen. So the hinge motion is basically just the condyle rotating in the TMJ compartment between 10 and 13 degrees, and that then gives you that 20 to 25 millimeters of anterior separation. Moving on to the translation, this is the gliding movement of the condyle along the glenoid fossa. So when we're thinking about these jaw movements, it's really important to use that to consider how we want to restore the dentition. So when we're thinking about the way the teeth meet together, the way the mandible's moving, we need to assess what's going to be the best position to restore a patient to. So there are 6 advantages to restoring a patient to the CRCP. So we'll go into those in a second, and there's also 3 disadvantages. And just a reminder that the CRCP is the centric relation contact position. So the first advantage of restoring to the CRCP is that it's a reproducible position. So every single time it's going to be the same. You'll be able to reproduce it even between appointments. Secondly, you can eliminate interferences with a stable tooth-to-tooth contact. And thirdly, an advantage is you get evenness of the occlusal contact. So you get like a balanced occlusion, and it's going to be even between the different occlusal contacts. Fourth, you get good control over the occlusion clinically, so it makes it much more in your control and much more predictable. Fifth, there's a mechanical convenience of this type of occlusion. And sixth, there's a technical convenience of doing this kind of occlusion. So disadvantages or times when this might not work so well is if you have a very occlusally aware patient. So if they're very aware of slight discrepancies and changes, this might not work for them. It could reprecipitate a TMJ click. So if the patient has a click in their jaw, it could get worse, or you may sort of create one through changing the patient's bite. And you can also lose anterior guidance and create posterior rubbing contacts as well. So there are two more definitions which you might have come across, and these are the Bennett movement and the Bennett angle. So to explain these, you should be able to see a diagram again over the top of me talking. So the Bennett movement is during lateral excursions. So it's the bodily shift of the mandible in the direction of the working side. So it's generally no greater than 2 millimeters. The Bennett angle is the angle formed in the horizontal plane between the pathway of the non-working side condyle and the sagittal plane. So that's approximately 15 degrees. And it's known as it's on the non-working side or the balancing side. So there are 5 features of an ideal occlusion, and we won't always achieve these, but like I said, it's in an ideal world. Firstly, in an ideal occlusion, we want anterior guidance. So when you do a lateral movement or a lateral excursion, we want the teeth on the working side to contact and immediately disclose teeth on the non-working side. So that's your canine guidance or your group function. We also then want in protrusive movements anterior guidance to disclude the posterior teeth to protect them. Secondly, we want posterior stability. So that's really important that we have a balanced posterior occlusion. Third, we want there to be an absence of posterior interferences. So ideally, we don't want any interferences with different movements of the mouth. We want everything to be working in harmony. We also want centric occlusion to be achieved at centric relation position. And finally, we want occlusal loads to be transmitted axially or axially through the teeth, so downwards through the teeth. And we can check occlusal contacts using either shim stock, articulating paper. Now the iTero scanners, that sort of thing, are amazing at scanning the teeth, and they can track tooth wear over time. So we can actually look at the occlusion using a 3D digital scanner. So I hope this was a helpful video. Obviously, occlusion is a topic which you could spend days teaching, and I'm sure that one video isn't going to miraculously give you an infinite knowledge of occlusion, but hopefully it has been helpful. Nearly everything which I've discussed today, if not everything, is what I learnt on the occlusion course I went on at the Advanced Centre of Excellence. So that was a really good day. I learnt, well, 3 days. I learned so much. There were only 12 of us to 3 supervisors, plus a lab technician, so we got really great hands-on experience. We had real patients. We made a Lucia jig, a Michigan splint, and we worked in small groups with a supervisor showing us what to do, getting that hands-on experience. So it was extremely valuable. I'd really recommend it. I haven't been asked to say this, but I think it's important to acknowledge them when everything I'm teaching you here is from their workbook and what I've learned from them. So what I've given you is probably a couple of pages of a 10-chapter 3-day intensive course, so it's just the cherry on the cake, really. It's a tiny little bit, the tip of the iceberg, shall we say. So I would definitely recommend that. If you've got any more questions about what I've said or about the course, please do reach out to me, and hopefully I can point you in the right direction and help.